it's netting to zero, but I think that might be creating a little bit of a apples and oranges when you're looking at line 5 to looking at the FY26 budget at the bottom.
Oh, you're saying it should be line, the equivalent ratio would be like line eight.
Line eight would be what you'd want to compare to the very bottom line there.
Okay, I will have to go back and look at that further. So that would be 8 million less in major commercial compared to 1.16. I think you would still have a pretty substantial difference in major commercial, a substantial drop in collections, even with an additional $8 million allocated there. Are there any other reasons why you would expect lower collections from major commercial?
Yeah, those are pretty much the lines that you, so it would be like lines 16, 17, and 18, where you see the rate decreases. Those would drop the collection rate for major commercial.
That's part of our rate reduction, and so we are expecting a reduction in reimbursement.
Okay, so it's really, that's the H266.
We've got the on 16, you can see our FY23 rate enforcement, our mid-year increase, and if you, when you get time, if you refer back to in our presentation, the breakout of how we applied that and got to the 7.9%. That relates to that column right there.
All right, thanks. I will look at this again in more detail. You can take that down, Matt. The other question I want to talk a little bit about is, in November of last year, there was an announcement about closing about 50 inpatient beds at UVM Medical Center. Did that occur?
We have taken beds offline. We've decreased the number of double occupancy beds that we had. We've trimmed back some beds on certain floors. So we have overall reduced our average daily census. Some days it's higher, some days it's lower, but overall average it has decreased.
So were there 50 beds taken off or not 50 beds taken off?
I think we haven't hit quite 50 yet, Dr. Merman, but I'd have to tell you, it's fluctuated a little bit. I think we're close, but I don't think we've taken the full 50 off yet.
And in that, my understanding, there's about 75 traveling positions that were eliminated at UVMMC through that. Were those 75 traveling positions eliminated?
I believe they were, yes. I believe that shows up in our data for current number of travelers.
Okay, so is that when we see the big reduction from the FY24-25 budget to the actual of traveler reductions, is it largely the 75 that those are in there, right? The 75 that were reduced for closing those beds?
That's a component of it. And also hiring and retention is also a part of it.
Okay. So it looks as if that's a really substantial part of the traveler reduction, though, especially within nursing from 25 budget to 25 actual. Do you agree?
There's a significant portion of that where we have filled with permanent staff.
Yeah. I'm just trying to figure out if you think it's realistic to drop from the 150 nurses to the 83 nurses for the 26 budget. Do you think that's a realistic goal?
So if you look at our current retention rates, which are very strong, and the success we're having in recruiting, I believe that is achievable.
Okay. I do have concern there that you're overly optimistic in reducing those travelers, which would lead to increased expenses.
I understand.
We're short on time, so I'm going to pass off and have a few written follow-ups for my other questions. Thank you.
Thank you.
I'll turn to the healthcare advocate. Sorry, Mr. Chair, you caught me. You surprised me by not going to your questions first, but I'll persist. Thank you for the opportunity to ask a few questions. First off, I want to recognize, appreciate UVM's tone and many of the words that you said in your intros. I think it is a different tone than I've heard in the past, and the words are clear that you recognize the urgency of the challenges in front of us, and I want to recognize that. I also want to, Mr. Vincent, you're right. You were correct earlier. Wouldn't be surprised if you didn't, from the likes of me and others, get a push to go further. So some of my questions will go there. But first, a high level discussion. About the challenges that are in front of us. And in the past, I know that when there has been discussions about UVM prices and measures like RAND has been used in the past, there's been quite a lot of pushback about the accuracy of that. And I kind of want to move past that if we can, and just ask whether UVM recognizes that at least in part, both the affordability and the system-wide challenges in front of us are related to UVM's prices. That UVM's prices are a significant factor in those challenges going forward. I wonder if you could comment.
So what I would say, Mike, is I also agree we should try and move beyond the data because we've spent way too many hours showing your data, our data back and forth into what's really going on. There's a crisis in the United States right now over affordability of healthcare. If you look at many states, many academic medical centers, many insurance companies like United are having real trouble right now with the cost of care. And so the medical center is a big part of healthcare in the state of Vermont. We're proud of that, but it does make our numbers big, and it makes our but it makes our opportunity big as well, and our responsibility. And so we have to work harder than we have in the past to make sure that everything we do is as affordable as possible for Vermonters. I believe we're taking that seriously and doing that in a way I haven't seen in my 32 years here.
I'll add, Mike. Do you mind if I add, Mike, or?
Yes, please.
Just to connect this to, I think this was a question that member Walsh asked earlier. So yes, our prices are a component of the struggles that we're having in Vermont in terms of affordability. And what are we doing internally to track how we're doing compared to in terms of impacting affordability? And I agree, like moving beyond the benchmarks would be a very welcome change, and I think would move the conversation forward in a more positive way. And one of those ways that we can start to track, at least this is only one metric, but it's connected to where the board has to go in 2027, which is reference-based pricing. So we can look at our total commercial revenue as a percentage of Medicare, and we can start to kind of have a conversation on where do we need to go with that number to impact affordability. That takes the noise out of what RAND is saying or any other benchmarks, and we can have a real discussion about this is where we're at now and where do we need to target, which isn't just pricing, but it's also some of the other things that we've talked about earlier today, where if we decrease utilization, if we move care to lower cost of care sites, the OSC, for example, was just one example of that, but starting outpatient infusion centers, looking at where the community can provide the services instead of the UVM Medical Center at potentially lower cost. All of that factors into that commercial percentage of Medicare that we certainly have started to look at internally in preparation for FY27.
I guess I appreciate this conversation. I'm going to take it a step further. we've all been at this for a while, and we've all been at various approaches to try and reduce spending by steering care to the right place. Good work, important work, work that hasn't delivered the kind of cost savings that I think we all agree we need. I don't think I have another question about that. I guess I want to comment a little bit about the who makes the decisions going forward. I know that we have the reference-based pricing framed up, and the board is hard at work hiring for that and developing a process for that. I wanted to reflect a little bit on the. It is no surprise to me that UVM and other hospitals want to have I'll use your quote from one of your team, hand on the wheel. I'm sure you wouldn't be surprised from my perspective, again, having watched this process for a long time and been in the in the battlefield with on various skirmishes, that from my perspective, the coalitions of the willing have not delivered the kind of changes that I think we're forced to contemplate. I did this last week. I just recognized how hard the Hospital Association and others, and I think UVM pushed back on at what became Act 55. I think that I guess I just want to ask for it's more of a statement as much as anything, but I think we have a push and pull going forward about absolutely we need the industry to be at the table to let us know the impact of the changes that are contemplated. But I'm making a public statement here and welcome your comment. But from my perspective, we're past the time of consensus and are going to require some really tough choices that are going to be hard.
So my comment to that would be reference-based pricing is a way to control prices, but has no impact on utilization. None, unless you don't offer the service. That's the only impact it has on utilization, and people have to go somewhere else. Global budgets, which we have a little further out on the timeline for the legislature, really is about total cost of care or utilization and price. They're not exactly perfectly aligned. I think not having providers at the table who have the biggest impact on utilization and how to keep Vermonters healthier is a giant miss. And so I can't imagine a path forward without having our expert clinicians at the table and the appropriate hospital leaders who know what the patients in their communities need, who are reviewing the CHNAs we just talked about for their communities, and making sure the whole state has reasonable services here for Vermonters, and then doing it as affordably as possible and figuring out how to cover that expense for Vermonters so they can get good care close to home. That's really what everyone wants. I don't imagine any model where not having provider experts there will work. Thank you.
I agree with you about at the table. We need input. Okay, I had a few questions about the audited financials. From your most recent profit and loss submitted to the board, it appears that your current excess revenue over expenses is currently 121 million. For the last audited financials in 2024, it was 259 million. Given the affordability challenges and system-wide challenges we've all been discussing, I wonder if you have a comment about if this is an appropriate excess of revenue over expenses for a nonprofit hospital.
I'll start with that, understanding that the way, and I know Rick's on as well, because when we do an audit, it gets done holistically over all of our organizations. But I will say it is important to recognize that we present our financials every single month to Green Mountain Care Board. We do review those, and there will be some variances between the audited statements and just the way things are classified. And I want to point out and recognize that that does not mean that there is cash at that level, and excess is quoted in dollars, but not in percent. And I think that's one of the things that UVMC really gets challenged with is the dollars as a whole. And it is important to understand that the dollars that are generated are based upon the care delivered and provided. So the so much in terms of specialty care, which is high dollar, high cost, is delivered with from our organization and our providers. And the cost of delivering that care is high. So it is important that we look at the percentage and not just dollars, because they are shocking dollars until you put it in perspective with what percentages those are. And Rick, I will turn the rest over to you in terms of our audit.
Yeah, the only other comment I would add, Mike, is just that total change or total net income, if you will, the vast majority of that, I know in 24, just looking just at the UVM Medical Center, that's just the change in the value of our investments. So it's not actually, cash in our hands, and that can switch in the other direction as well. And that value of those investments factors into our days cash on hand. And I think I spoke to kind of where we're at as a network. Through the end of June, we're at 131 days. So I just, that's the only other thing I would point out is that the vast majority in any given year of the difference between operating revenue and the final net income is just the change in the value of our investments from one year to the next.
I appreciate those answers. It sort of leads perfectly into, I wanted to read a quote from Fitch recently about UVM Health Network. Quote, at the end of FY24, UVM Health Network had unrestricted cash and investments position of about 1.3 billion, which is up about 27% year over year, and improved cash to adjusted debt of 168.4% from 125.2%. I'll finish the quote. Maximum annual debt service MADS coverage was 4 times as calculated by Fitch, and that was the strongest it's been in over the last 5 years. That's the end of the quote. So I'm not going to ask the exact same question again. UVM's in a particularly strong position. I've heard answers to your questions, to board member questions about why you didn't go further in reductions. And I've heard the answers, correct me if I'm wrong, that you looked at all of your financials and decided the right amount given all your financials. And so I just leave that on the table, that as we're facing what feels to me like not just an affordability challenge, at some point enough people can't afford coverage and care that the system really falls apart. So I keep wanting to describe this as a system-wide healthcare financing challenge or crisis. I'm gonna leave it at that. It's hard for me from where I sit to look at that and not at least need to say it out loud. Sam, I don't know if you're with us and you wanted to ask a question or two.
Yeah, I am. Can I just do a quick sound check? I lost power. Looks like everyone in our town did. Can folks hear me okay?
Yeah.
Okay, I'm on my phone. A couple questions. Mr. Vincent, you said earlier that the New York hospitals are now operating at break even or small margin. I'm wondering if there are any plans to pay back the loans that were on the audited financial sheet, or if they've been paid back already.
So just to clarify, because we're an obligated group and we're consolidating entry, those dollar amounts that we've been talking about are not loans. We actually can't even describe them as loans because we're one organization. So it's funds flows that we're tracking internally that many systems across this country don't even do that type of tracking because they're paying all of their expenses out of one bank account. So we're not at that point yet. And so we're still keeping track of that. And we will, finances are improving, and those will shift over time. Exactly where they will land in the years ahead and whether or not we make the transition that many other organizations or many other systems have made, yet to be seen. We'd have a discussion with the Green Mountain Care Board before we did that, just to make sure that it was clear in terms of, the changes in the reporting that they would see. But just to be clear, those are not, they're not technically considered loans, and they can't be considered loans, as part of, since we're one organization.
Okay. I'm curious if there have been any conversations about no longer owning the New York hospitals to improve the financial position of the obligated group. Because from the latest analysis that we've done and we've seen, it looks like the overall performance of some of the key financial metrics of the obligated group would be better if the hospitals were not a part of the network.
Can I take a clinical answer to that before you answer the financial one? Sorry, I just can't help myself. So, Sam, if we didn't have Plattsburgh and Malone and Elizabethtown over there strong and able to take care of the appropriate patients in New York, the medical center would be overwhelmed. We need those hospitals to be able to provide appropriate good care in those locations. And so the power of the network is everything we're showing you is all the challenge we have with inpatient capacity, access to our specialists, and so on. We need those hospitals to be strong and vibrant. They are doing better. They're at the presentation Dr. Harrington gave about adding doctors to those locations to keep people local. And so I understand that it looks appealing to say, boy, if you just weren't losing money over there, that'd fix everything. But the impact to Burlington and Chittenden County for local care for all of us that live in Chittenden County would be devastating to not have strong hospitals on the New York side. We get about 30% of our patients some months for certain services from New York. We need that for our specialists, but to have even more come would overwhelm us. So I just have to put that in there that from a clinical standpoint, that would be very difficult to manage from a patient care standpoint. Now you can get the finance answer, but thank you for letting me speak up.
Yeah, the financial answer, Sam, is very similar to what Dr. Leffler just stated. I mean, it's the same reason why having nursing homes within our organization helps the overall finances of the organization. We want patients to be cared for in the most appropriate location, and keeping patients local helps us financially because it allows us to keep the access that we need and the capacity we need at the UVM Medical Center for the patients that truly need that level of service. Otherwise, financially, that would just be disastrous, as Dr. Leffler said, to have to take care of all those patients, low acuity patients that don't need the level of service that the academic medical center is able to provide.
Okay. My last question is a kind of a detail one from something you wrote in the narrative. It's on page 11, appendix U1, and it reported out your management FTEs and costs. It looks like the total amount that you're spending is going to be about $4 million higher in 26 compared to 25. And it looks like there's 619 FTEs in 2026, looks going down about 1.7. Just wondering what led to not decreasing that number further, and actually, like, on a cost basis, it's going up.
I say I'm actually pulling that to ensure that we get the right page. When you're looking at management as a whole, you've got senior leaders, VPs, AVPs. We've got a lot of directors and supervisors. So of that 4 million that you see going up, 1.9 million is our supervisors. And those are critical to training our new staff They, as we talked about, bringing in RNs and really looking at having permanent staff versus our travelers, supervising that staff, training them, and also giving our existing staff a pathway for advancement is right in alignment with Act 68 in terms of that attracting and retaining um, quality healthcare professionals. So that's our largest increase, and I think that that is critical to improving quality and patient care and all the components that go around with that. When you look at what has happened in terms of FTE reductions in senior leadership, we had submitted a slight reduction in the kind of executive level. So we did take a look at that. But I did want to clarify that the largest is where we're making the investments in supervisors and managers and directors.
Okay, thank you. Those are my questions.
We're an hour over, which is by our standards for UVM pretty good. So I'll quickly turn to staff and then we will adjourn and come back for CVMC. I'll turn to Mr. Sutter.
Thank you, Chair Foster. I just want to follow up. Board member Walsh asked about utilization variances. Judy, you said that there have been, and I hope I'm phrasing this correctly. You said there have been little significant utilization variances in terms of percentages. But in your actuals reporting where you attribute the NPR overage to different drivers, so utilization, reimbursement, payer mix, bad debt, free care, et cetera, we're seeing something a little different in terms of impact. So year-to-date actuals for 25, you've reported NPR over by about 3.8%. And of that, 85% you've attributed to utilization. In 24, the NPR overage was 4%, and you attributed more than 100% of the overage to utilization. Similar things for FY23 and 22. You've reported that the primary, in some cases, only driver of NPR variance from budget has been utilization. So I'm just wondering if you could square there being like little significant utilization variance on a percentage basis with those little variances driving significant NPR overage.
You're exactly right. When I referenced our variances in utilization, I think there are multiple ways that we need to look at that. One, utilization by what? Is it an increase in utilization that we're seeing for uninsured? Is it increase in utilization that we're seeing for commercial? We did see a significant increase in utilization, but in our commercial where people were seeking care. We also saw that in our own employees, in our self-insured component. And when I look at percentage wise, I am looking holistically at our percentage that we're projecting, but there has been movement between categories, and we have been able to look and say, is it rate or is it utilization, and break all of that out. So thank you for the opportunity to clarify that.
Thank you. Chair Foster, I have a few more questions about shared services, but in the interest of time, maybe it makes sense to save those for the network. Or I can ask now. It's your preference.
Go ahead now.
Yeah. So the FY26 budget shows the health network pharmacy, so network department, total expenses increasing to almost $11 million. It's a $4 million increase from budget and a $5.5 million increase from your projections. The department has no direct revenue, so the full expenses are allocated out to the hospitals. I'm just wondering what the department is and why the expenses are projected to increase nearly 60% from budget and over 100% from projections.
So I can start, Judy, and I don't know if you have any more details. The vast majority of that is related to our retail operation. So as it's growing, which I think you've seen the revenue increases there for retail and contract pharmacy. That's the expense side that's growing to support that growth. In addition, we have continued to embed pharmacists within clinics to help again with medication adherence and to ensure that the quality of the medications and the encounters that we have in that space are important. The other piece too, I think, I don't know if Mark explained this when he met with you this week, Matt. Every year we do make some changes to shared services, and it's not just an incremental increase. Some of it is it's a shift from what was a hospital cost now moving into shared services so that we then allocate it to the whole network. I think there was some of that as well in that health network pharmacy, that it wasn't just a pure new increase, but it was a cost that was moving from one of the hospitals into that shared service funding model so that every partner would pick up a piece of that cost.
Great, thank you. I did have another question about the Population Health Service Organization. Your direct revenues for it are down pretty significant from budget. I was just wondering what you think is driving that, and also how do you generate PHSO revenues?
So that one we may have to follow up a little bit on that, Matt. I can give you kind of a high level explanation there. So some of that revenue decline, I have to believe is OneCare going away. So that is where we map most of those population health management payments and the care coordination payments, because it's that team that then has the infrastructure that supports our clinical operations. So we line up the revenues with where the expense is housed. The other place that department has started to generate revenue is through providing their services to those outside of our health network. So we do have a contract with UVM, the university, not the health network, where they're providing care coordination support for their employees. So their revenue streams are starting to expand. It's more than just kind of the traditional payer add-ons and quality incentives and care coordination payments. They're starting to look outside of the network to generate revenues.
That's it for me. Thank you, Chair Cost.
Mr. Vincent, you testified that some of the pharmacy expense increase could be shifting hospital cost. How much?
You know, we can give you the detail of all of the transfers that were made into shared services this year, Chair Foster.
Okay, great. Okay, we'll take a break for half an hour. We'll come back at say 1:10. And we'll take up the CVMC budget at that time. I'll try and make up a little time, but everything will be pushed back a little bit. But I'll try and feel like an airline pilot trying to make up time. Okay, we'll take a little short recess. Thank you.
Like a week.
Mr. Pratt, I see your hand is up. Or not on the record, but I was just noticing it. Oh, sorry, you're muted. Well, so
Oh, Chairman Foster, I was wondering if there'd be public comment at the end of this session.
yeah, there is. It's at the end of the entire day. There's public comment. It's on our agenda. It'll probably be around 5:30 or so.
Okay, thank you.
Okay. All right.
Yeah.
Good to see you.
Good to see you.
Okay. All right, Mr. Miller, are you back?
Yes, I'm back.
Okay. All right, we can go back on the record, please.
Okay, we are on the record.
All right, we will resume our hearing of the UVM Health Network Hospitals. Ms. Noonan, I see that you are here, so we'll turn it to you and your team for your presentation on your budget.
Great. Thank you, Chair Foster and members of the board, for the opportunity to meet with you today. Central Vermont Medical Center submitted a FY26 budget that's compliant with the Green Mountain Care Board budget guidance that includes a 3.6% commercial rate decrease, a 3.5% NPR increase, and a 2.8% operating expense growth. To clarify, our submitted narrative noted a 3.3% commercial rate decrease, so I just wanted to call that out. Our budget balances quality, access, and cost with CVMC's long-term sustainability to care for the 66,000 people who live and work in the 26 towns and cities in central Vermont. This year's FY26 budget submission, coupled with the mid-year adjustment proposal that we discussed last Wednesday, and the discussion we'll have on the 13th, reflect our commitment to balancing affordability while ensuring quality and access to the vital healthcare services that central Vermonters need. In FY24, CVMC achieved a positive margin of 1.7%, our first in 8 years, following 7 consecutive years of negative operating margins, ranging between a negative 0.6% to a negative 6.5%. That margin was achieved by providing access to services that our community required. Fiscal year to date, CVMC has a slightly favorable positive margin, and in FY26, we essentially budgeted at break even. We must remain financially stable to provide care and services, appropriately invest in the equipment and facilities, and most importantly, continue to offer competitive wages and benefits to our most important resource, our staff and providers. CVMC utilizes lean and other methodologies to improve the efficiency and effectiveness of our services. To date, we have put 240 members of our team through intensive lean education. Huddle boards, a methodology to track improvement, are openly displayed in units and departments across CVMC. The staff run those huddles addressing operational and clinical issues that arise real time, along with tracking and trending performance on key clinical and operational metrics over time. In May of this year, we held a quality forum. This forum highlighted 49 improvement projects from across our organization. Each project exemplified our deep commitment to improving quality and safety of the care and services we provide. 5 awards were presented to teams who demonstrated exceptional improvements in categories such as stewardship, innovation, patient-centeredness, simple solutions, and partnership. An example of one of these awards was presented to the emergency department and care management teams for their efforts to identify ED patients who did not have a primary care provider. The project goal was linking patients to a PCP, and that effort has begun to show a positive impact on reducing some of our ED utilization. Our improvement efforts also focused on hospital-acquired conditions. Since March of 23, we've had 0 central line-associated blood infections. We've had 0 catheter-associated urinary tract infections since October of 24. And fiscal year to date, we've had 0 surgical site infections and our total joint procedures. Fiscal year to date, these performance improvement efforts have also resulted in a reduction in falls, pressure injuries, length of stay, and readmissions. This progress, however, is not reflected on our CMS star ratings due to the lag in data for this public reporting, which includes data from 2019 to 2023 for Medicare patients. Our care teams will continue to actively work to improve our performance so future scores reflect the quality that we know we deliver every day. CVMC is the only community hospital in Vermont to receive certification as a primary stroke center. Primary stroke centers are associated with reduced morbidity, and multiple studies demonstrate a decreased 30-day and 1-year mortality for patients cared for in these centers. CVMC is also a resource for intensive care and acute care services for 8 out of the 14 hospitals in Vermont. This new referral pattern frees up capacity at UVMMC for the tertiary care only they can provide. In addition to clinical efficiencies, CVMC is reducing administrative costs by $2.8 million by working collaboratively to streamline and address redundant administrative services both here at CVMC and across our network. This includes the elimination of 8.4 FTEs in leadership roles, a $1.1 million expense savings. Through innovative workforce development programs, which began here at CVMC in 2020, we've graduated 41 LPNs, 22 RNs, and 1 respiratory therapist in the last 5 years. These programs are now part of our systems level Center for Workforce Development. Efforts like these have enabled us to reduce our travelers by 23.2 FTEs for an estimated savings of $3.4 million in fiscal year 26. Additionally, to promote workforce recruitment and retention, CVMC leases 20 market rate rental units within 5 miles of the hospital campus and subleases these to CVMC employees. To support the expansion of much needed childcare for our team, we've made an investment in regional childcare provider, which will be located near the hospital campus. We will have 25 spaces per year for the next 5 years reserved for CVMC families. In addition, the UVM Health Network's housing and childcare initiatives in Chittenden County are available to all system-level employees. In fiscal year 26, CVMC will continue to fund our employee share of the child care contribution that was enacted in July of 24. These efforts, in addition to more traditional tuition reimbursement and wellness programs, are all ways in which we support our team. In the area of external partnerships, I want to highlight Thrive, Central Vermont's accountable community for health. Pardon me. This regional collaborative was created to address the social drivers of health and improve the well-being of residents in Washington and Northern Orange counties. CVMC serves as the convener and fiscal sponsor for this 20-partner organization. Thrive's focus is aligned with priorities identified in our community health needs assessment, which we just recently completed. These initiatives range from sponsorships of programs that address substance use prevention and treatment through the work of the Central Vermont Prevention Coalition, which we are the conveners for, to a campaign focused on lowering the rate of single female head of households living in poverty. And this year, Thrive was honored to receive the Public Health Champion Award from the Vermont Public Health Association. The award was presented at the association's annual meeting and recognized Thrive's work in promoting public health, our effective and collaborative response following the regional flooding that we experienced in the summer of 2024. As I mentioned, over the last 9 years, we have leveraged Thrive's partnership with their employees and their client base to complete our community health needs assessment. We've identified our identified needs for this fiscal year and for this 3-year cycle are also in alignment with the state's 2025 to 2030 health improvement plan. Next slide. Our primary care providers have completed the transition to tracking productivity using a risk-adjusted panel size. This, coupled with improvements that you heard earlier that are related to operations, such as standardized schedules, has allowed CVMC to create more access to primary care. As of March of this year, we now have 24/7 coverage for our certified nurse midwives for our labor and delivery service. This has been a strategic priority for CVMC for some time, but it was just actualized this year in March. CVMC providers have performed over 1,200 electronic e-consults, a 15.6% increase over this time last fiscal year. As mentioned earlier, an e-consult gives primary care providers the ability to ask a question of a specialist through the EHR. And we feel that about 80% of the time, these e-consults result in the patient not having to be referred to a specialist. This frees up time for the specialist to see other patients and reduces costs as e-consults are billed at a lower rate. Enhanced referrals that you also heard mentioned earlier can clarify tests that may be required prior to seeing a specialist. This process avoids visits where the patient was seen by a specialist only to find they needed a test in advance of that visit. We are continuing to standardize ambulatory clinic schedules. This work has been completed in primary care, cardiology, and endocrinology, with plans to spread this to other services across the next 18 months. Standardized scheduling allows patients to leverage digital tools such as the cancel and reschedule function to optimize the provider's schedule. We are on pace to have a third of our practices utilize this function by this fall. Lastly, I want to mention our Skilled Nursing and Rehabilitation Center, Woodridge Rehabilitation and Nursing. Woodridge falls under CVMC's tax ID and is integrated into the CVMC's fiscal year 26 budget. With our aging demographic, the demand for post-acute services continues to increase. As a system, we have aligned these facilities under a single division to gain efficiencies and continue to focus on improving outcomes. The FY26 budget for Woodridge reflects an average daily census of 145. Our commitment to provide post-acute care services, improving throughput by reducing the number of long-stay patients in our acute care beds, and providing resident-centered care in a more appropriate setting is our goal. In closing, CVMC remains committed to our efforts to improve quality, maximize the efficiency of our operations, expand access, and address affordability for those we serve. We also stand ready to advance collaborative partnerships to support these goals. And now I'm going to pivot and introduce our CFO, Kim Patnode, who will review in more detail our budget proposal. Kim?
Thank you, Anna. Thank you, Chair Foster and members of the board for allowing us to present our budget for the 2026. I'm going to give you a little bit of a background on where we're at for fiscal year 2025. Right now, we're looking at net patient revenues exceeding budgets by about $10 million, which is 3.5% of what we had initially budgeted in 2025. 56% of that variance is related to utilization, particularly in the areas of outpatient services for endoscopy, I can never say that word right, for GI services, imaging services, which include diagnostic, CT, PET, ultrasound, lab services, and pharmaceuticals. Of that $10 million, approximately 6.5 of that is related to major commercial payers of Blue Cross, Cigna, and MVP. We are instituting a mid-year rate reduction that we did present to the board on August 6th. That is about a $6 million reduction to our commercial payers of those same three that I mentioned above, Blue Cross, and Cigna, and MVP, to reduce our reduce our burdens to our commercial payers. In the same net patient revenue space, as Anna alluded to, we have Woodridge Rehabilitation and Nursing Facility that is in our budget numbers, and they have a $1.9 million unbudgeted favorable variance, and that's related to the extraordinary financial relief funds that we applied for in the April-May time period of last fiscal year, which is on a state fiscal year. We heard in January of 2025 that we received this enhanced payment for our Medicaid residents, and that was in effect from January to June. We did not put this into our budget for 2026, as the nursing homes are in a rebasing period for 2026, and the need is not there. Our expenses are coming in over budget by $15.8 million, or that's 5.1% budget variance, and there's contributed to 6 areas. One is our staff salaries. We're $7.1 million over budget. And that's really tied to the fact that you will see later on our presentation that we have 3 union bargaining units now that are in our encatchment areas, one for RN, technical professional, and most recently the support services union contracts. Our fringe benefits are also $4.4 million higher than budgeted, and that is again related, as with everyone else, a higher employee healthcare costs as well as pharmaceutical benefits. Our traveler use continues in 2025 to be $3.2 million higher than budget. And that is not only just in nursing, but also in our ancillary spaces of respiratory therapy, imaging, and our nursing home. Our medical staff salaries are $2.3 million. Our pharmaceuticals, as the revenues are increased, so are expenses, and that's really related to our higher cost oncology services. We do have a couple other areas in our purchase services that are coming in above budget. One is anesthesia coverage. We have a hold harmless arrangement with the UVMMC Health Center, and that is a hold harmless arrangement with the anesthesia providers where we pay the difference between what the physician is paid versus what they bring in. And we are having to rely on a little more on locum coverages, so the locum does cost us more. The other cost in our purchase service space is also in our Woodridge Rehabilitation and Nursing Services, and that is for a management contract. On the next slide, you will see our overall utilization areas. Most of our volumes are within the 5% FY25 budget, with the exception of 3 areas. That's inpatient resident, short stay, rehab services. We'd originally bumped that resident stay to an average daily census of 145. We are getting there, but at the beginning of the fiscal year, we were struggling to meet that dollar amount, that ADC, and I'm most happy to report in the last couple of months, we are hanging around the 140 mark. So that means we're getting the right patients at the right level of care. We are still seeing higher volumes in our CTs. That is coming mostly from our ED areas. And as Anna alluded to, we do have the Joint Commission certification for our primary stroke, and that we're seeing a lot more utilization in the CT scans to rule out strokes. And our GI is running higher. As a reminder, our GI services are primarily driven by by an independent GI group that is part of our team. Moving on to net patient revenues, again, just a real high level. I want to clarify, our narrative did say we had a 3.3% commercial rate reduction. It is actually 3.6%. The delta between the 3.3% and the 3.6% that we are proposing is about $500,000. Excuse me. I'll break down that 3.6% commercial rate reduction in the next couple of slides. And we are looking at a 2.8% overall operating expense growth. So where are we at moving from fiscal year 25 to 26? We are putting in a 3% charge master increase, very similar to what UVMMC has provided for an answer on their charge master increase. When we do our budgets, we do look at several things. We build our budget based on utilization. What do we anticipate our budgets are? Again, we are building a budget with a very short time frame, looking from October to January time period, and then look in the prior fiscal year to see if there's anything different we've missed in the historical that we need to incorporate into the budget. We also look at different things, including new recruits, departures. New recruits, obviously, in the physician space need to always have ramp-up time, so we have to make sure we adequately account for ramp-up time. Any technology changes, I think one of the questions came, are we using AI? Is there AI that will help us enhance our efficiencies, access initiatives? And then the seasonal factors that are not included from October to January. Typically, if you look at January, February, that is your higher inpatient utilization. So you don't want to build an entire budget build on the January, February time period. In our net patient revenues, we are primarily driven by our utilization, and the rate adjustments are estimated to be minimum. In our expense pace, where we are looking at for the 3% in guidance, we have a $5.1 million increase due to inflationary costs, which are more than half salaries. We have $1.9 million increase due to volumes for pharmaceuticals and supplies, a $1.5 million increase due to medical staff salaries, and then we have a $6.3 million efficiencies for clinical that are going to be reducing expenses. As part of being part of the network, we also have the opportunity to lean in and really standardize a lot of our care and making that happen as a team. Overall, CVMC is reducing our overall staff FTEs of 34. This is inclusive of 23.2 FTEs, and that is not only at the hospital, but at the nursing home as well. Overall, volumes are continuing to trend within 5% of our 25 budget, with the exception of 4 areas. Our clinical visits, we are expecting a 4.4% increase as related to the improved access that Anna indicated. We've increased a bump in our CT scans. We anticipate that's going to continue to be above our budgeted volumes for 25 and for the stroke rule out. GI cases, again, working through those backlogs of cases that we had with our independent GI group. And then our build lab tests. We have one of the rare opportunities is we have increased our reference lab capability, and that's really done through the lean work that the lab department has done to create efficiencies to take on more tests. Moving into the net patient revenue assumptions specifically. You will see on this slide that we do have an update also in this slide as well. We have updated numbers for our Medicare increase or decrease, I should say. It's a net decrease of $511,000. We are broken that down between inpatient improvements of $415K and outpatient services is a reduction of $927,000. CVMC will have to make up the differences and with additional focuses on effort for efficiencies in our efforts. We are not anticipating any FPP adjustments. Our net patient payer mix, as you can see, there's a very small shifts between payer mix and overall the reduction in net patient revenues from payer mix is about $1.4 million from the FY25 budget. Just as a reminder, we are highlighting the major commercial budget decreases. On the next slide, I will talk a little bit more about how that 3.6% reduction in commercial rates or commercial rates will occur. In our budget narrative, we did, as I said, note that we had a 3.3% major commercial rate reduction, but it really is a 3.6% that does tie to our rate decomp file. The difference, again, just to confirm, is about $500,000. When we started our budget, you'll notice that our commercial rate increase is 2.3%. That is really it's about 3/4 of the 3%. That is part of the allowed budget increase because our rates don't go into effect until January 1st. But when we were putting our budget together, we weren't clear on what the Act 55 pricing reductions would go into effect. And at the same time, we were planning a mid-year rate reduction. We thought the Act 55 would go into effect on July 1st, which might negate the need for a mid-year rate reduction in 2025 fiscal year. We budgeted a 12-month impact for the Act 55. Now that we know that the Act 55 is only going to be 9 months affecting the fiscal year 2026, the true impact will be $5.6 million instead of a full $7.5 million that we budgeted. This gives us a little bit of wiggle room to continue to look at increasing and improving any efficiencies as well as access. Moving into our bad debt and free care slide. We have not adjusted for anything material. As part of the UVM Health Network, one of the things that is really a benefit to us is we have standardized our free care practices and policies, and it's a centralized services that is through shared services. So any patient who calls in will get the same level of care regardless of which partner hospital they are engaging with. Moving to case mix and operating mixes, you'll see our case mix is relatively flat. We have a very heavy medical population, which means we don't see a lot of variation in our case mix index, either between Medicare or all payers. I would be remiss if we didn't talk about what does this mean and where do we land in our operating metrics. You can see from our operating margin, we are making a very slim to no margin. Our days cash on hand is very low, between 73 to 79 days cash on hand. But the good news is we do have the ability to take on debt if we needed to. Moving into other revenue, the majority of our other revenue that shows up for CVMC is really in our 340B space. We are anticipating some reduction as to do with additional manufacturer restrictions. Moving out of labor and moving out of revenue and into expenses, we have very high level of what we're looking at. Total FTEs, again, as I note, we have an overall reduction of 34 FTEs, which includes 23.2 FTEs that are travelers and the eight leadership positions that Anna noted from the beginning of our presentation. Overall, our total expenses in labor, we are anticipating $5.1 million related to inflation, which is more than likely most of our salaries. We have $1.5 million that's tied to our medical staff, And we also have $5.2 million increase in our employee benefits. This is a new slide for us. As I had started in our conversation, we have our union contracts and our non-union for our non-union employees that work at CVMC. We have several contracts you'll notice that are also tied to UVMMC that are on ours as well. These individuals work here on CVMC campus, and that's why we picked up their contract amounts in our budgets. We have about 58% of our staff that is new to us, that is under a contract and is higher than the 3% allowed budget variance or the inflation variance that the Green Mountain Care Board has offered. We've also moved into our non-salary expenses. I've broken this down between the several factors. One is, what is the increase related to our budget increase for non-labor expenses between utilization, inflation, and other factors? Other factors, we're looking at reductions, you will notice, in spaces around creating additional efficiencies. That is the biggest driver in our other factors. I will also tell you in our utility space, that is a little bit of a bigger bump from year over year in our budget. We had a 5-year contract that ended with our natural gas vendor. Very, very few choices to come into this space. 5-year contract ended. The vendor came in and came back with a pretty substantial increase that we're having to absorb as well. So with all of the changes we're making with Act 55 and to continue to make our system as affordable and accessible to our community members, what are we doing for major savings and financial impacts? We have our traveler reductions, this 3.4% or $3.4 million. We're reducing our administrative expenses. And then our cost of care expense reductions. Again, as part of the network, we're able to really lean in and standardize our care as physicians and staff migrate from one of our partners to the other. And I'll turn it back over to you for closing.
Yeah, so I think we've just provided a high-level overview of our FY26 budget submission. We're seeing that we're in compliant with the Green Mountain Care Board's guidance. And at this point, I just turn it back over to you, Chair Foster, to open us up for questions.
Thank you both very much. I forgot to announce one procedural step, which is Dr. Merman will not be participating in the CVMC budget as in years past, and he has stepped out. He's recused himself from this matter. I'll turn to Member Teachout for her questions.
Great. Good afternoon. Thank you. I appreciated the clarity, but I just want to make you go through it one more time. The differences from what you're truly asking for and what was in your narrative and other documents. So instead of a 3.3 commercial rate decline, you're asking for 3.6, and you said the difference is about $500,000 between those two. Also on page 7 of your narrative, you say that you're asking for a 3.03% charge master increase, and now it looks like that's just a flat 3.0. Am I correct?
That's correct.
Okay. And then again, same page, I think you showed in your slides new commercial numbers that put you at negative 3.6 for inpatient, outpatient, and professional. Okay. And is that the same numbers that you would also use on page 15 of your narrative? It looks like the same chart repeated.
Let me just pull up that narrative real quick.
And I guess just to ask my question, you've got a 3% charge master change increase for next year. How do you plan on applying it across inpatient, outpatient, and professional? And is that what I'm looking at here, or is that something else?
I'm going to, if Kelly Shapney is on, she is my resident expert on charge master increases, and I'm going to look for that page 15. Member teaching.
Hi, Member Teach Out. Yes, we're looking in aggregate inpatient, outpatient, professional. The per code or area is actually still in development, given we're, pending budget decisions, but that is an aggregate how we're looking to apply the charge master.
Okay, and I guess when you're looking at the budget this morning, you had specified how it would go across the three. So I wasn't sure why you couldn't do it here.
I don't think I said it it's a similar answer, and if I misstated or said it in a different manner, what I said earlier and how we apply charge master increases is in general to get to the aggregate 3% due to various needs, again, going back to the conversation of lesser of and identifying codes that have moved around, and with our payer revenue, there could be some tweaks, but it's a similar, and if something was said differently, it is in the same approach that we take at CVMC.
Okay, I guess then to zero in on the outpatient, you have for CVMC an even number. And I thought that the difference before was attributable to the H266 cap. And so I was just curious that it didn't show up in a similar way in CVMC as it did in UVMMC.
So I think there's two components. I'll start and then turn back over to Kim. In terms of during the legislation and H266 at the time, the largest revenue impact, as you saw, is at the medical center, and we did a lot of analytics and were able to drill in. Given the timing of budgets, both with CVMC and I'll say with Porter, and the different impact, getting to honestly the impact of the drug purchasing capabilities at both hospitals, because it is different from the 340B status. The budget doesn't reflect the nuances we were able to capture in the medical center. A lot of that was timing, given when the legislation came out, us not knowing July 1st versus 1/1. So that's a reason why there's differences between the two budgets.
Okay,
Kim, feel free to add anything, but that's the general answer.
No, that's what I would have said too. Thank you, Kelly.
Great. So I will jump to a different question. I wanted to ask about how CVMC benefits financially from being part of the health network.
Well, I'll start and then I'll let Kim jump in. So I'm going to approach it more from clinical and operational perspective. So CVMC, I would say, has benefited from being part of the network in a number of ways. First and foremost, if CVMC was standalone, we would not have the EHR capacity and other type of system level IT tools would not be available to us as a community hospital. Being part of the network has allowed us to really leverage those tools, which have optimized our efficiency in many ways and absolutely has helped with improving our clinical outcomes. So that's a very simple but broad example of the value of being part of a larger network. Another area that's been helpful to us is in recruitment. So working with the departmental chairs, our chief medical officer, Dr. Clauser, and our team have been able to really recruit key professionals, particularly in the specialty category that we in the past had struggled to recruit into our organization. And those individuals now are being recruited into practicing at UVMMC as an example, and also CVMC. So they go between partners, which is really helpful. So that's just a few examples. And I think it also works in the reverse. CVMC had some real innovative practices in the workforce development programming that we launched in 2020, and those are now spread across the network, right? So I think those kind of collaborative efforts go a long way into optimizing our clinical outcomes, but also improving the efficiencies of our operations. So that's just my piece of answering that question. I don't know, Kim, if you want to add anything more to that.
Yeah, the level of expertise that our network does bring would be something that we'd be remiss at having to probably outsource more, particularly like cost reporting, reimbursement. And we also are able to create efficiencies through our revenue cycle. We are completely consolidated as part of our shared services and revenue cycle space. We've also been able to lean on our network in spaces like payroll processing, We had an individual leave several years ago. I chose not to replace that individual, and our network colleagues, as part of the shared services, leaned in and helped us take care of our payroll issues here at CVMC.
So do you benefit from every one of the shared services that are available through being part of the network? Or are there ones that you use more than others, or do you pick and choose what's most appropriate for your organization?
So as part of our shared service model, we have the opportunity to access any shared service that's available. So I would say that there's some that we use more than others, but by and large, what we've done is, instead of having those resources local at CVMC and investing locally in that, those services are now part of the network. And so we can optimize just by scale those kind of resources versus having to have one of each of those types of services within our own organization. So I think overall, it's really an efficiency opportunity. And out of that has also come a lot of standardization, which I think anytime you standardize, going back to putting my lean hat on, you end up reducing waste, right? I would say that it's overall advantageous for CVMC to have the ability to access those resources and shared services as needed. But some of them are standardized and available across all partners.
Great.
And that's the intent. That's the intent.
And then would you say that the benefits have grown over the course of the arrangement?
Well, I think more and more shared services have, more and more services have become shared over time. So by virtue of that, they've expanded, our ability to access those have expanded because those shared services that were once part of CVMC or part of any of our partner organizations are now located at the network level. So by virtue of that, I think there's been expansion.
Right, that all makes sense to me. So then when I look at the amount of shared services that CVMC pays the network for, it looks like your total dollar amount that you're paying in has actually declined significantly. And I was looking just at FY22, and at that time it was 23.2 million. And I'm looking at the amount before the expense gets netted out. And it's dropped to 16.8 million. So, and that was 6% of the total, down to 3.2. Can you talk about why that's changed, both in a dollar value and as a percent?
So just as we've become more efficient with local operations here, as a network, we've become more efficient with shared services. So over the last several years, there have been reductions in shared services as we've learned to systematize and optimize those services as well. So the benefit of that is we've seen a reduction in our expense related to those services. And I would imagine that we're going to continue to see improvements in that arena over time as we leverage IT solutions, leverage AI. You heard that earlier, and Dr. Leffler and Judy Picklee's presentation. As we do all that kind of systemization, the cost will come down. It doesn't happen immediately, but it does happen over time. And I think that's part of why you're seeing a reduction. We're seeing a reduction at CVMC.
Okay. Yeah. And I appreciate those examples. Do you have an example specific to what's happened between 22 and 26?
Not off the top of my head. I'm trying to think. It seems like such a long time ago, but I'm sure there are good examples that we can share with you, Member Teachout.
Okay, thanks. So I did want to jump to your 340B. You're assuming lower revenue, and you said, quote, additional manufacturer restrictions. What are you thinking? Because I know that H266 did do some changes to protect your contract pharmacy revenue.
In that space, there's always federal regulations, and manufacturers don't always play by state rules. So that's what we were anticipating at that moment in time.
Do you think it's changed at all since the passage of H66, your sort of outlook on that particular revenue item?
At this moment in time, I'm optimistic.
Yeah, I'm happy to add a little bit to member teach out. So yeah, for 26, so there's no doubt that the legislation will help our contract pharmacy arrangements. 26, it'll take a little bit of time, according to our pharmacy team, it'll take a little bit of time to actually see the benefit of that. But when you see our budgets next year in FY27, you'll see hopefully some significant increases in contract pharmacy revenue for all three of the partners. But for this fiscal year, it'll be a little bit muted just because it's going to take some time for all of that to get put into place.
Okay. So you're already seeing the reductions in the revenue because of that, and then now that the new law is going to go into effect, it'll take time for it to reverse. Is that what you're telling me?
Correct. We're still going to continue to see declines in contract pharmacy between now and December, which is
Okay.
we've got three months of our fiscal year is October to December, and once January comes around, that legislation will help. Even that, the light switch is not going to go off on January 1st. It will take some time for that to work its way into our finances. But the hope, as Kim said, is that we will see some benefit in our contract pharmacy revenue.
Okay, so will the benefit be, just to put a finer point on it, a decline, a reduction in the decline, or an increase in revenue? Do you know what I'm asking here?
Yeah, it should really be essentially a stopping of the decline. We've seen the decline over the last 3 years, and the legislation should allow us to recoup some of that decline that we've been experiencing.
Okay, great. Thank you. That's super helpful. And now I want to ask about e-consults, because all across the network budgets, but especially in yours, you talked about the benefit that's having for patients and for opening up access in your system. And I wanted to ask specifically about how these e-consults are billed. Can you talk about that?
I'm going to defer to Kim or one of our network experts in that. That's not my expertise, unfortunately.
Kelly, I saw you come on. Did you?
Yeah, maybe I'll take a shot at it.
Sonny.
Member teach
Sorry,
out.
Sonny.
So no worries. So the way that the e-consults work is that when a patient goes in to see their primary care physician, I'm just going to make it up. Let's say they need to see a rheumatologist, or the primary care physician feels that there's a rheumatologic issue there. The way that the e-consult works is that the primary care physician fills out a form, sends it to the rheumatologist, sort of behind the scenes, with very specific questions and specific components of the history. Then the rheumatologist will look at that. And Brad, please jump in if I'm misspeaking here. But then the rheumatologist looks at that and looks at the assessment, looks at the information that's there. Sometimes we'll have to go back in the chart. This is where, as Anna mentioned, being all on the same system, they can pull out all the information that they need, and then responds to either, here's what we need to assess, diagnose, and or treat without necessarily seeing me. And about 80% of the time, they're able to do that by just sending that message back to the primary care physician, who can then initiate any one of those steps without having to go see the consult. There is no charge on that. Nothing goes out. Internally, now what we've done is we've created more work for that primary care physician, because before all they had to do was put the consult in, and there's a little more work for the consultant without actually seeing the patient in that space. But on the other side of that, the 20% that they then flag to say, yes, we do need to see this patient, then they expedite that. And so the goal there is that you're seeing patients that actually have real need to see the consultant. Those patients, of course, then get to the consultant and generate the normal legally required charge that goes with that. But then otherwise, in that in-between step, though, in those 80% of successful ones, there's no additional charge that goes out to the payer. Brad,
Well,
I just want to please I just want to make sure that I'm not misspeaking on any component of that, because I don't want you to think that there's something deceptive going on there. There isn't. I just want to make sure, Brad, can you just verify or correct me if I'm wrong? Don't hold back.
Yeah, for sure. And member teach out, I'm going to kind of jump to the end because tell me if this is not the intent of the question. So e-consults have separate codes that are billable. They are all billed to insurance companies. The fee schedules for those insurance companies are significantly less than what it would be for a full consult. Some data I've looked at is probably 25% to a third of what a consult would actually bill out. So the math behind that, of course, is the challenge of how many e-consults can you do, versus how much time it would take to see a patient in person. Does that get to the question a bit?
Yeah, and I kind of was wondering if this counted it as an asynchronous visit or not.
I think internally it's a good question. Internally, we don't count it that way. I mean, we genuinely look at the number of e-consults and then building out, over time, additional e-consults for more and more specialties.
And you also provide this service for independent docs who are not part of your network?
Not yet. We've been working in fits and starts to do that with a few different entities. And some of this F2HCs, the interoperability is a challenge. And so we have 2 organizations we're working with right now to work through that with some manual workarounds, meaning the staff will have to, grab that documentation for the patient from the other record and help move it into the Epic record. So we continue to look for partners, but I want to be really transparent that the lack of interoperability is a challenge.
Okay, great. I appreciate the detail there. And my last question is about the discussion of the CT scans for stroke rule out, and whether or not CVMC is unique in what you're doing, or if this is happening across many facilities.
So in the state of Vermont, I think we're the only community hospital that has that primary stroke center certification. But across the US, organizations that have that certification would see similar utilization rates for CT scan.
Okay, so the additional CT scans you're doing is part of the package of services for this primary stroke center.
It's part of the standard of care for when the patient arrives in our ED as part of the diagnostics, yes.
Okay. And can you, in a little more holistically, talk about how that helps the patient or how that helps the system, or, something along those lines?
Yeah, definitely. So as I mentioned in my opening remarks, there is lower morbidity and mortality rates with patients that are treated in these type of stroke centers. So there's a pretty rigorous set of criteria that one needs to meet to be designated as a stroke center, a primary stroke center. And we have performance measures that we have to continue to maintain to keep that designation. So we just received that designation late last summer, and we've already had our first review again, not even a year later, to make sure that we're hitting all the metrics that are required to maintain to continue with that certification. So it's an ongoing higher level of standard that we need to meet for this population. And the results for those patients are pretty dramatic. So if you can impact quickly on a patient that has the signs of a stroke, their long-term sequelae are minimized. And obviously with that are better long-term outcomes for that individual patient. So it's something we're really proud of doing, something it's a full team effort. And then obviously we're connected to the UVM Medical Center for that even higher level of stroke care. So we often will stabilize, treat, but if they need more invasive interventions, they would go to UVMMC as a tertiary quaternary care center to provide that level of stroke care. So it's a great partnership, and I think, again, really exemplifies the value of being part of a network.
Great. Thank you. That was all the questions I had. I appreciate the clarifications.
You're welcome.
Member Holmes.
Great, thank you. And thanks for the presentation. And again, like all the work leading up to it. I wanted to start, some of my questions were answered, so thank you for great questions, Member Teachout. I did have some additional questions though. On page 6 of the narrative, you state, as demand for healthcare services increased throughout our region, CVMC's hospital outpatient services will not be able to meet this need in increased volume as we reduce expenses to achieve compliance with GMCB budget guidance for fiscal year 26. Can you explain which specific outpatient service needs you will not be able to meet for your community this year?
Well, I don't know that we specifically are looking at any reductions in outpatient services. I think that might have been a reference to some of the changes we made as part of fiscal year 25 with the consolidation of some of our practices, and both in rehab and primary care. But we're not anticipating specifically any reductions in services.
Okay, so you would say that your budget doesn't include any eliminations of any services. I know
That's
you have
correct.
inpatient psych, but other than
Yes.
that, there's no elimination of services.
That's correct.
And your sense is that the consolidation in rehab and primary care, I think you just mentioned, but that doesn't constitute a reduction in service.
Correct. So we've just moved some of the fixed costs by consolidating. We're optimizing some of the fixed costs in practices that already exist. So we're improving efficiencies as a result of that, but the service should be the same.
Okay. It looked like from the department FTEs, it looked like you're planning 6 fewer clinical FTEs in family medicine. How will that not create a reduction in access to primary care?
So I'm going to defer that question because I don't have the details of those specifics, unfortunately.
Okay. Defer, you mean to somebody else or to another time?
I saw Brad just came on, so he probably has all the detail there. Thanks, Brad.
Yeah, Member Holmes, we can follow up on the specific detail. The methodology behind it is related to the primary care risk-adjusted panel sizes, the overall observed to expected. So I just want to mention that as well, but we can follow up on the specifics of that.
Okay. It also looked like you're reducing staffing in PT from 16 to 11, according to that department FTEs. So it seemed like that would also create a reduction in access to physical therapy in the community.
So thanks for asking that question very specifically, Member Holmes. For our rehabilitation services, there are a number of community providers that exist in our market. And so we've been able to work with them to see if they have opportunity to take on some of those referrals, and they have. And so we have, as we've reduced through attrition some of our rehab services staff, we have not needed to replace them. But and we have reduced from, I think we had 7 rehab practices, we're now down to 4, with some of those therapists coming into those practice sites, again, optimizing the fixed support staff around them. But we also are trying to move services into the community, which I think is one of the goals of our health reform system.
Okay, I just want to be clear though, when I'm asking about a reduction in services, I'm asking about a reduction in services that CVMC is offering, not really thinking about, is there a reduction of services in totality in the community? It sounds like there's some shifting of patients from CVMC potentially to independent PT providers in the community. To me, that would be a reduction in services offered by CVMC. Do you see the difference in how I think about it?
I appreciate your explanation. Thank you.
Okay, so with that understanding of reduction in services in mind, are there any other services that you're anticipating reducing the provision of by CVMC, whether it's going to be offset by independent providers taking that up or not? Is there any other reductions in services we should be aware of?
No.
if we're making adjustments to benchmark calculations for provider transfers, as we just talked about in the UVMMC discussion, should we also adjust for reduced or eliminated services like inpatient psych or PT so that we have a true apples to apples comparison year over year?
I'm sorry, could you repeat that again? Member
Sure.
Holmes?
I'm thinking about, let's talk about inpatient psych, for example. So we're making adjustments. We make adjustments sometimes when we're calculating benchmarks for provider transfers, right? The assumption is that the care is being delivered somewhere else in the system. When you add a provider onto the books, that care had been delivered somewhere else, right? So that's the rationale for adjusting for provider transfers. I guess what I'm asking in this case is, in the case of reducing or eliminating services like inpatient psych, which was on the books for fiscal year 25, is no longer on the books for fiscal year 26 because those beds are gone. To have a true apples to apples comparison, should we be removing the fiscal year 25 associated NPR from the inpatient psych, for example, to have a true apples to apples comparison of growth in NPR from 25 to 26? Presumably that care is being delivered somewhere else in the system. Those mental health patients are seeking care somewhere else. So that NPR still exists within the system, just not at CVMC any longer.
When we resubmitted our fiscal year 25 budget in November, the NPR was adjusted to take out the impact of the inpatient psych unit as of December 31st.
Okay.
So it had 3 months worth of NPR, which was upside down because we were losing money in that service, in that space.
Okay, so the NPR from 25, the inpatient, when we look at budget to budget from 25 to 26, the $4 million, I think that's what it was in NPR, but I could be wrong about that. That might be not, my memory is not great on this one. Is that included in your calculation of the growth in budget or not?
We would have backed it out for our 26 start. When we do our budgets, we back stuff out that we know is being pulled out. Just like if we were adding a service, we would be adding to that. I think I'm clear. I'm following your question, Member Holmes.
So I think maybe, so the 25 budget, what I took from what Kim said is that it already included reduced revenue. So the guidance gets applied to the 25 budget to come up to and compares that to the 26 number. So I think there may be 3 months that's missing there, Member Holmes, but I think the vast majority of it has been captured in 25.
If there's any follow-up to that, that would be great, just to make sure that we're apples to apple comparing. I want to ask about expenses a bit, because to meet, again, this is similar to my questions I suspect about UVMMC and probably the same for Porter. To meet the expense growth target, there's a heavy reliance on reduction in travelers. And I think to meet the budget to budget reduction, or the budget to budget expense target, it requires a reduction of 23 travelers, which is a 26% reduction budget to budget to save $3.4 million. Different than UVM MC, in 25, you're actually over budget by $3.2 million because of higher than expected traveler use. So when you look at and I think you said in your testimony, it was $3.2 million over 25 budget for travelers. So when we add the two together, the delta that you're anticipating is over $6.8 million or $6.6 million. If my memory is right on what you said the deltas were. I'm really trying to understand, is that realistic? To go from where you are at for 25 projected to where you need to be in 26 to achieve the expense growth target that you're anticipating?
Member Holmes, I would have to get you the detail, but keep in mind our nursing home is part of those numbers as well. And under our new management contract, the hours per patient day ratio with our clinical staff at our nursing home has tightened down what we're needing for our travelers. And we're also looking obviously under the contract, our recruitment efforts to maintain and recruit and retain our existing nursing staff is also at play as well. And then I know we have one respiratory therapist that we've graduated and will be part of our team that was a traveler at one time. And we've also been able to convert an MRI traveler from a traveler to a permanent staff member as well.
Okay, well, any additional follow-up that would help us, you know, understand how feasible this traveler reduction is going to be, and if you need to break out what the, you know, the nursing home is relative to the hospital and what progress you've already made, you know, since this budget was submitted and projected 25 would be really helpful. I also, similar to my question from, you know, to UVMMC, I think the ability to do this depends a lot on culture and, you know, your ability to recruit and retain and convert to permanent. So it'd be really helpful to see those employee you know, satisfaction surveys to understand, you know, how easy that might be to do. So if you could follow up with that, that would be helpful. And I would just say the same thing for Porter. I won't ask, but it's similar questions. I'm really trying to understand if this is going to be possible. And the same question I would have for you, if you can't achieve the traveler reductions that you hope, and I hope you can make them, but if you can't, where will you find cost savings elsewhere to ensure that you don't compromise access to care?
So I'll start and I'll let others jump in. So there's a significant effort in optimizing clinical efficiency. And that means just looking at the practice that we have and seeing where there's opportunity to reduce costs that doesn't add value to the patient or improve the outcomes. So I think we have some opportunity there. So we're looking at that across the network. And specific to CVMC, we think we might have some opportunity in that regard. But we're going to continue to look at efficiencies across our system. I mean, one of the reasons why we're a lean organization is our staff find those opportunities for improvement. And so we've empowered them to go ahead and make those changes and make those decisions. And we support them in that by removing any barriers that they may have to impacting those changes. So we're going to continue to look to see what we can find to improve both clinical efficiency and operational efficiency. So it'll be on us to really stay on that and make sure we achieve them if we don't meet some of our currently budgeted savings.
Okay, and your commitment then is also not to compromise access to care and not eliminate services.
Correct.
Okay. And my final question is around some of these e-consults. It sounds like there is some wonderful expansion of e-consults, which would save travel time for patients, save cost to the system. And I'm wondering where in the budgets collectively we might see the offsetting reduction in revenue expected from specialists visits.
So you would see that in net patient revenue, Member Holmes.
And it specifically, has it been booked in across all of the hospitals? Is there an anticipated cost savings from each hospital in each hospital's budget for the reduction in specialty visits associated with the increase in e-consults?
Brad can speak to, I think, in terms of savings, I don't know if that's exactly the kind of the necessarily the term. I don't think that it was approached that way, but Brad did, and his team did build his budgets based on a certain number of e-consults, a certain number of clinic visits. And so I'm sure over time that ratio has changed so that the impact on net patient revenue is in our budgets. But I'll let Brad expand on that a little bit more.
I don't know if you'll, I mean, I'm thinking through your question. I don't know if you'll see the direct offset because of the total demand. Recognizing, I think the question is about, tell me if I'm wrong, how the individual provider spends their time, right? So I think it's more of how much are you taking in for e-consults versus how much reimbursement is there for consults? Is that
No,
the
I think the
question?
question is, I think the premise is that if your primary care provider can do an e-consult and save that patient, and some fraction of those visits to a specialist no longer need to occur, right? Because of that e-consult, there's some fraction of visits where the information from the specialist back to the primary care prevents a necessary visit. I would expect that we would potentially see a reduction in specialty visits. And so I'm trying to see, to some degree, I'm trying to understand the true magnitude of the cost savings here from e-consults and increasing, or reducing rather the number of specialty visits. So I'm trying to see where it might land in the budgets. Does that make sense?
Maybe I totally understand your question, Member Holmes, and maybe I'll just throw it in, but Brad and Ramsey, my understanding is that we targeted these areas for specialists that were in such high demand that we were struggling to maintain access for them. And so, I mean, to go back to what Rick was saying, I think you try to do the calculation. The challenge is there's a little more work in the space in between. Work RVUs are not going to go up as a result of that. But what you do get is the folks that are on that waiting list to go see a specialist actually get the answer and go see the specialist. So I don't know if you're the end, I think I used a rheumatologist. If you're the rheumatologist at the end of the day, I think you're seeing just as many patients as you were, minus the effort that you were putting into the e-consult. They're just that the consults are more relevant, that you needed to see them in person. We've served considerably more patients in that time because there's less time, easier for the patient. I don't know if that actually will, the decrease in revenue to the consultant will be less overall. But if that's going to be really, I mean, maybe you've done the calculation, Brad and Ramsey, I don't know, but if that makes sense. So if you're seeing 20, I'm just going to make it up. Just if you're seeing 20 patients a day as a consultant, and now I'm going to do 5 e-consults and I'm going to see 18 patients a day. There'll be a little decrease, but the point is that we're hitting 23 patients now instead of 20, right? That's the goal is, and I think we really targeted the e-consults, and I see Ramsey's hand is up, so please correct me again. We targeted the e-consults to areas where we just weren't able to deliver the consults that patients were waiting for and our primary care physicians were asking for. And so the goal there was to increase access where we were struggling to be able to deliver access.
Okay, so I guess where then we would see it is in a much higher reduction in wait times for those particular practice areas. We should be seeing that come to fruition between this year and next year as e-consults come online.
Yeah, I think you would see it
I
think that would be a really good measure. So if a primary care physician, if you go to your primary care physician and you needed a rheumatology consult and you were waiting 6 months to get that consultant, you would see a much shorter time period now for those patients that needed it. And I don't know for measuring that again. Yes, if I'm thinking the same way you are, the answer should be yes. And I'll toss it. I don't know the answer, and I'll toss it back to Brad. And I see Ramsey's got his hand up to be able to, but I think you're absolutely right. That would be the logical conclusion.
That's the correct conclusion for sure. If the supply and demand remain the same, and where we've seen where the demand goes up, it's really hard to show in the high level because you don't see the wait times moving, that even though the demand's going up, the wait times are not moving the way we would like them to.
Hopefully the combination of refer backs and e-consults should help that problem, I would hope. Okay, those are my questions. Thank you so much for answering.
Member Holmes, Dr. Harrington's had his hand up for a little bit. So
I'm sorry, I can't see that. Sorry about that.
That's okay. Member Holmes, I wanted to comment on the inpatient psych transfer dollars. I just want to explain clinically what actually happened, because it may help the way you're thinking about this. So when inpatient psychiatry was closing, we knew that the group of patients who are utilizing those beds almost entirely flow through the emergency department. And so we actually employed 2 emergency psychiatrists to provide coverage in the emergency department. And we tacked on some tele support in the evening times. And so it was a change in the service in the emergency department. And mental health challenges, just like I'll use chest pain as an example. When a patient comes and sees us, sometimes we can actually manage that patient in the outpatient setting or in the ambulatory setting rather than admitting them to the inpatient setting. And we knew before the closure that relative to other facilities in the state, the patients that were coming to CVMC were relatively lower acuity. And so the trend that we started seeing is that the mental health patients that were coming in were being seen by emergency psychiatrists in the ED. And with the work that Anna and crew have done with the support services in the county, what we're seeing is that those patients are actually oftentimes not being admitted, where when we had inpatient psych beds open, those patients were much more likely to be admitted. The take-home point of that is, because we had emergency psychiatry services in the ED and community services, I bet when we get a full look at the data, we're going to see that we actually admitted fewer patients and managed them more in the outpatient setting than we would have prior to the closure. And so, are you following what I'm trying to say? Okay, great. Yep. And so I'm going to guess that the total expense is going to be less and not fully transferred elsewhere in the system, but there will be some of that, yes.
Okay, no, thank you. That's helpful. Those are my questions, Chair Foster.
Thank you. And just noting that time, we're a little tardy. So Member Walsh, go ahead if you have anything important for CVMC.
Yeah, just a couple of quick things. Thanks for being here this afternoon. And members Teach Out and Holmes asked great questions. I'm just wondering, does your local board independently evaluate the value of shared services in your budget?
Member Walsh, you're asking if CVMC's board independently
Yes.
evaluates?
Yes, that's right.
Not as specifically, but they certainly ask questions about the services we get from the network, and of course, members of our board are also members of network committees and such, so that they have a sense of how shared services works. But if they have any questions, usually it's a conversation with myself, or if needed, which hasn't been needed, the leader of that shared service could also speak with our board. But we have those members come into our board meetings and give updates as part of our board agenda, so they stay pretty relevant with the services that are being provided.
So kind of board to board members, how often are shared services discussed in open board meetings with the public?
So our board meetings are open to the public, but I will be honest and say very rarely do we have public members that join those meetings, but they certainly have the ability to do that. And as I mentioned, routinely on our agenda, we have presentations from network shared service leaders presenting at our local board, so that they get a sense of the services they're providing, initiatives that are underway, and have an open exchange with those leaders related to those specific shared services.
Is there an example from the last year or two where there was a significant budget decision that was approved locally without the network being involved?
Nothing that's coming to mind.
Okay, that's right. Your hospital is carrying the same percentage increase in shared services as UVMMC, 30% higher expenses for high value care, 51 for medical service. You have a smaller operating base and more limited resources. It seems to me like this could function like a regressive tax. If it's heavier to carry, the smaller you are. So how do you evaluate whether the increases crowd out local priorities or stretch your staff capacity, especially in light of your response to member homes. There are services that are decreasing: primary care, the number of FTEs, physical therapy. Are those reductions part of an impact from sending more money out toward shared services?
So our percentage of shared services for CVMC is about 14.2%, I think, of our NPR.
Right, but it's the percent increase. So the percentage increase in shared services is applied equally across facilities. So the high value care aspect of shared services is increasing 30.17% at CVMC, Porter, and UVMMC. So that increase is what I'm worrying about as a regressive feature.
You're correct, Member Walsh. The shared services are allocated on a proportional basis of total revenue. So everybody gets their share based on how much total revenue they contribute to the overall network.
So, I worry at a smaller place that it would leave less money locally to address local needs. But thanks for the answer. That's all I've got. Back to you, Chair Foster.
Okay, thank you. Anything from the healthcare advocate?
Nothing from the healthcare advocate. Thanks, Mr. Chair.
Great. Okay. We'll take a brief 5-minute break and come back at 2:33 for the Porter presentation. Thank you. All right, good afternoon, Mr. Ortmeyer.
Hi, good afternoon, Chair Foster.
How are you? You guys all set?
Yep, all set.
Okay, we'll go back on the record then.
On the
Mr. Miller?
record. Yeah,
Great, thank you.
on the record.
All right, thank you, Chair Foster and members of the board. Good afternoon. I'm Bob Ortmeyer, President for Porter Medical Center and Elizabethtown Community Hospital in New York. I've been with the network now for 4 years as president of Elizabethtown and for Porter in my joint role for the last almost 2 years now. This is going to be a bit of a familiar presentation, similar to last year, as we set the stage to a lot of reorganization here at Porter and through other efficiencies leading to what's been accomplished this year and prepare us really leading into the future. As my colleagues have mentioned, our work this year is focused on delivering high quality care, access, and addressing the rising cost of healthcare. So a couple things about Porter, critical access hospital, employs 704 people. Of our 123 licensed beds, 25 are the acute care beds, 98 at Helen Porter. Serve a population around 32,000, employ 77 providers, and 206,000 patient care encounters over the course of the year. And this includes 14,000 emergency department visits, which if you're all familiar with our emergency department, it's pretty tight conditions there, very outdated as well. Just wanted to draw something to, I think it's something you hear with all the different hospital presentations as well. Of our population here, that 32,000 overall, significantly aging. The overall population is declining by 8% over the next few years, along with the working age population declining by 31%, presenting a pretty significant challenge there. But this will also continue to challenge our access to specialized services as the population ages, as well as stress our already in high demand long-term care environments. Porter has had a financially stable year this year, maintaining our current budget. It was our intent to submit a compliant budget this year with the current budget orders. This, however, was not without its own set of challenges. Many of those issues have already been talked about, so I'm not going to go into a whole lot of detail on them. But significant work has been done this year around quality here at Porter. A gap analysis on the CMS star ratings was performed in September of 24 upon receiving our July of 24 CMS 2-star report. Accurate data collection and reporting were identified as an opportunity for improvement, meaning that some data and the metrics were not accurately reported in the past. Mortality and readmissions were identified as areas of strength, while patient experience and safety of care will be a major area of focus for improvement this year. The quality metrics, according to the star ratings, are monitored for improvement on a monthly basis now at Porter's Quality Improvement Committee, which is also attended and staffed by Porter board members. Porter now has a projected star rating according to CMS of 3 stars for the next reporting period. You move on to the next slide. Thanks. This past year was a great recruiting year, and the Porter community has benefited from this, from new clinicians joining the network and working here in Addison County. This is inclusive of primary care. Their offices are open, with the exception of one right now due to retirement, but don't want to jinx it, but hopefully we'll have a new recruit in there in the fall. In those open offices this year, we've added around 350 new patients into the patient panels, as well as many additional specialists. We've onboarded orthopedics, cardiology, hospitalists, psychiatry, oncology, and several advanced practitioners. In addition to this, there's been a 21% increase, dare I say, in e-consults, about 573 year to date. And this is really getting those patients who really need to get to the specialist in their schedule. And all this is access for our communities. The Community Health Needs Assessment has identified the same high-risk areas for attention this year, which includes access, which we are significantly addressing this year, as well as mental health, substance abuse, and housing. I mentioned our work already around access. with the recruitment, and you've heard about the medical groups initiatives earlier. And we partner with the counseling services of Addison County for services in our ED, and we've inserted psychiatry into our primary care offices in Middlebury. This year, telepsychiatry is being planned in our emergency department to help expedite dispositions of patients. We continue to explore how we can support our local developers in the housing area, and this is beginning to take shape in the Virgins and Middlebury areas with affordable middle-income housing opportunities beginning to become available. This is vital to attracting and retaining our workforce. You've heard about the work around clinical productivity from the medical group, and that spans into Addison County as well. We are continuing to standardize the ambulatory clinic schedules, standardized scheduling, which allows us to leverage those digital tools you've heard about. We are continuing to meet the ongoing needs of our patients. Actually, meeting the ongoing needs of our patients with appropriate facilities is an ongoing challenge. And we're preparing to begin construction at our Pond Lane facility for combined orthopedic and rehab practice to support the demand, as well as just recently having completed an extensive planning process around an appropriately sized emergency department. The current ED is severely undersized for the 14,000 patients that visit annually. Our work in the post-acute area begins on day one of admission, and initiatives this year have been on case management and a dedicated utilization management resource for Porter, which helps facilitate patient placement at a more appropriate pace, allowing for inpatient admissions to help partner hospitals with capacity. Also, external relationships, such as with Addison County Home Health and Hospice, are allowing patients to get to the right level of care in a more expedited fashion. Although Helen Porter Nursing Facility is not part of the hospital review process formally, I'd be remiss if I didn't mention it's important to the community as the sole long-term care facility in Addison County, which is financially supported by Porter Hospital. Helen Porter is now part of a larger system initiative around a coordinated approach to post-acute care operations and patient placement. This has been successful to date on many levels for patients and staff, as well as reducing the financial loss primarily through traveler reduction and addressing billing processes. There are significant expense pressures that we've been hearing about all day. We have an ongoing review of our processes here to gain efficiencies, whether that's a clinical process or administrative. And we put a particular focus these last 2 years around our administrative services and have reduced the cost by eliminating duplicate roles, at least 10 at this point, with Elizabethtown Hospital, a critical access hospital with adjacent geography to Addison County. I spoke of this last year, and these efficiencies have continued with a shared savings now between the two hospitals of $1.75 million annually. In addition to this work, Porter has reduced its travelers from 44 to 19 currently going into the new year. And in fact, Helen Porter has reduced their travelers from 33 at the start of the fiscal year, and we're down to 9 currently. Porter's reduction was made possible by revising the inpatient nursing structure, which was a shared learning from Elizabethtown. This saved $1.2 million in staffing. And our workforce pipeline partnerships have also helped fill critical positions that would have otherwise been filled with travelers. Our pipeline partnerships have supplied, just to give you some examples here, the following new employees this year. For licensed nursing assistants, we have seven new employees from the Patricia Hannaford Career Center. LPNs, we've employed 3 new LPNs from Vermont Technical. RNs, really good year with our RNs this year. 4 pipeline participants from VTSU and 2 from North Country, and 7 new graduates and 7 new external hires. So a great year of recruitment through our RN program. All these adjustments have allowed for a decrease overall of 42 FTEs in our budget. This is inclusive of some other open positions that we've opted to eliminate, resulting in an annual savings of $4.9 million. These savings have been instrumental in allowing Porter to continue to cover the operating losses of Helen Porter Nursing Facility, again, which is a value community resource here. So really overall, there's no significant changes in volumes or services provided here, but rather continue to look at how we do things that drive efficiency through increased collaborations, either locally, regionally, as well as across our system, resulting in increased access to care for the communities that we serve. So to dive into the numbers a bit more here, I'm going to turn things over to Scott Como, our CFO.
Thank you, Bob. Good afternoon, everybody. Just picking up on Bob's sentiment, my goal in the next few slides is to not only show how we're financially compliant with the guidance issued by the Green Mountain Care Board, but how we're really pushing the efficiencies and the collaboration opportunities that we have within our jurisdiction to reduce cost. And as you'll see in a couple of slides, it's that actual cost reduction that's playing a very big part in bringing this budget together. Next slide, please. So I'll just start with where we are in the current year against the current year plan. And the top level is we're coming in very close according to plan. And our 26 budget is really an extension of that plan. As Bob mentioned, we don't have any new services or any really spikes, no declines in volumes per se. It's really making do with what we have and trying to do as much as we can. So looking at this graphic, the projected volumes against our original budgets, really coming in close to plan, ED visits, medical group, OR. The one anomaly we see on the upside are the MRI and CT scans. And we've intentionally expanded our access to try to decrease wait times, not only at Porter, but at other partner affiliates. So that is something we are incorporating into our budget coming into next year. The other thing I'll just note is at the bottom of the page, our inpatient swing number. While the percentage number is large and the actual numbers are not, it is a very meaningful piece of Porter's not only operation, but financial picture. And so we saw a dip in the last 12 to 16 months of the swing patients that we've had come to our inpatient unit. And we're sorting through it, and a lot of it has to do with us finding our role within the overall case management mix of the network. And as you'll see with our budget in 26, we are expected that swing bed census to rise. But it's an important piece of our business, and not only from a volume perspective, but as I'll touch on in a minute, from our revenue perspective as well. So I'm going to spend a couple minutes on this slide because this is where I think it mostly comes together. And I'll start with the FY25 budget against the 25 projection. So the volume picture that we went through on the previous slide is generating a net patient service revenue projection of about 129 million against a budget of 130 million. So again, coming in really close to plan. The one thing that's not reflected in that volume summary that we just reviewed was we did have to implement a slight decrease in our Medicare payment rate. And this gets into the nuances of being a critical access hospital, because an increase in cost does not equate to an increase in reimbursement from Medicare. And that is something we found out, and it ties back to our swing bed census. That was a big driver in the level of Medicare cost reimbursement that we were allowed, because it is inpatient-based, it is hospital-based, and it didn't materialize to the extent that we were expecting. So the net patient service revenue projection here does reflect a slight decrease in our current Medicare rate, but we are anticipating a bump moving forward. Other revenue is coming in $2.1 million above budget, driven primarily by utilization of our 340B contract drug program. Salaries is where a lot of our work is happening. And so in the current year, when we started the fiscal year in October, we were in the middle of contract negotiations with a technical and support services union at Porter, and we were not sure where those negotiations were going to end. We did our best to budget our expectations, but we ended up settling at rates slightly higher than we had budgeted, and that is the primary driver for our salary run rate being over the original budget. However, now about 66% of the staff base is unionized, and that adds a lot of stability in our ability to plan and predict salaries in the future. And that really was a tool to our advantage going into budgeting for FY26, because a lot more of what we were committed to there was known. Fringe benefits are slightly under budget in the current year because our staff FTEs are under budget in the current year, and we don't have as much utilization of our health plan and benefits as originally budgeted. The non-salary expenses are coming in very close to plan, doing a lot of great work to manage the puts and takes that happen throughout the course of the year, so that total expenses slightly over original plan of 129 million against a budget of 128. But at the end of the year, we're going to be coming in very close to our original budgeted income of 6.3 million with an expected operating income of 6.2. So things not shaking out exactly the way we originally budgeted them 15 or so months ago, but landing very close according to expectations. So now I'm going to move to the FY26 budget, and specifically as it compares to the FY25 budget, because that is a lot of where our reference points take place. So net patient revenue in FY26 budgeted at 134 million, which is up 4.5 million over the 25 budget, which is the 3.5% budget guidance. There are three major inputs into that net patient revenue growth. There is some incremental volume over our current run rate that I'll get into in the next slide. There are some rate increases included. We do have a 3% commercial rate lift built in, as noted. We also have a 3% increase in our current Medicare reimbursement rate, again, tied to some increased inpatient volume expectations. And I should note that we also have an increase in our bad debt and free care rates, recognizing what's going on today in our community and what might possibly happen in the future. Our free care percentage rate was increased by 0.75%, and also built into our net patient revenue expectations. Other revenue is up year over year, 2.1 million. Again, a continuation of the community utilization of the 340B program. And salaries is where we've done a lot of work. And as you can see, our salary budget for FY26 is 64.8 million, which is $500,000 less than the salary budget for FY25. And that is with significant wage increases built in, which we'll get into on a future slide. So we were able to do that basically with three ways. One was a rate reduction, and the rate reduction comes in the form of the travelers. As we've talked about a lot, just any traveler that you have, the rate for that traveler is coming down. We've also looked at our staffing mix in certain areas and really have staff operating at the highest level of their license, which really allows us to maximize, the wage rate that we're getting. And as Bob mentioned, we've continued to experience operational efficiencies working with Elizabethtown. I have more details of this work in the next slide. Year over year, our fringe costs are going up by $900,000. We do expect an increase in our health benefit cost, as well as an increase in our permanent staff FTEs. The non-salary expense increase of almost $3 million. I have that detailed out on a future slide of the inflation drivers there. All adding up to a net income of $9.7 million, forward income of 6.9%, which I recognize is higher than it is today, higher than the budget in the previous year. The rationale for us needing that higher margin is linked to our continued support of Helen Porter Nursing Home. And as I'll get into in a future slide, unfortunately, the Helen Porter Nursing Home operating income is expected to erode year over year. And so to make the overall bottom line work, we had to wring more out of the hospital margin. So next slide. So on that net patient revenue increase, the utilization driver, this speaks to, year over year where some of those volume increases are. Of note, they're very consistent with the run rates that we saw on the projection slide. However, OR cases on this slide are budgeted to increase by 14%. We're currently running at 4% over budget. So this is a slight increase in cases. A lot of work trying to keep Addison County residents closer to home. And we have the OR capacity and provider complement to do it. The other note here is the increase in our average daily census. On the acute side, we are up to a 14 patient average daily census and we're currently running in the 11 to 12 patient range. And we are also budgeting a swing patient average daily census of 4, and we're averaging closer to 3. And both of those have yet to materialize, but we are in active conversations again with our network partners to create a path to make that happen. We have the capacity to do even more. Sorry, Jake, go back one more. As you can see in FY25, our swing patient budget was an average daily census of 6. So we do have the inpatient capacity to do it. We just need to find the right mix of patient and staffing complement to pull it off. Okay, go ahead, Jay. This is really a summary of some of the inflation assumptions that were built into the numbers that we just covered. On the left-hand side is a rundown of our expense inflation assumptions. Again, there is a slight bit of utilization change built into the budget, but not much. Most of the year-over-year dollar change is seen as a result of price changes and cost changes. At the top, you can see we do have a 4.5% increase built into our physician salaries, 3.7% into staff based primarily on our contract obligations, and a 2.2% increase in traveler rate. But overall, if you move to the right and to the lower right, you can see our FTE assumptions is where the dollars really start to shift. Now, I will say on the physician line, it looks like physician FTEs are going down by 2. We are actually offsetting that with APP providers, and overall, our clinical FTE effort is going up by 1.9 FTEs organization-wide. The staff and the traveler reductions are through some examples that I'll highlight in a future slide. And I was listening to the CPC presentation. So member Holmes, I will be sure to follow up with some information about the traveler reduction in particular and why we think that that's cheap. So next slide, please, Jay. So a lot of this Bob touched on briefly in his overview, but we did see a 42 increase of FTEs in total across all categories year over year. In particular, contract labor, travelers, 18.9 FTEs or 44.6%, which contributed $2.9 million to the annual spend on travelers. So that was a reduction in cost that's captured. We also had a restructure of how we staff our inpatient unit. This was a great piece of work between our CNO and other CNOs in the network. And really what it results in is an overall lower level staffing mix with proper oversight. So a decreased reliance on RNs and traveling RNs, more reliance on LNAs, and an overall 3.4 FTE reduction. So not only an FTE reduction in efficiency, but also how we deliver the work, resulting in a $1.2 million a year savings. And then Bob touched on our continued efficiencies with Elizabethtown. Since we were here last year, we've added a director of laboratory to that list of shared leadership positions and a director of pharmacy services to that list of shared leadership positions, continuing to look for opportunities to bring the two organizations together through attrition or otherwise. So in this summary on the left, really calling out the the Porter Hospital margin budget request in context with the Helen Porter budget margin for FY26. The driver of the erosion of the Helen Porter margin is really the lack of presence of EFR in the FY26 budget. Guidance given from the long-term care leadership through correspondence with DEVA was that EFR was not a surety for FY26, so we did not build that into the budget, which led to that margin erosion. Overall, our FY26 has a combined margin of 3.3%. It boosted our days cash on hand back to 110, which is still fairly meager. But as Bob mentioned, we have our eyes on an investment in an emergency department at some point in the future. When I look at our budget, and I just want to call out a couple of identified risks, we spent time with the with UVMMC and CDMC talking about their response to Act 55. We did not build any response to Act 55 into our budget. As Kelly Champney described, we took the work on as a network, looking at where it was going to have the biggest impact first. The impact of Porter is going to be between $2.5 and $3 million a year. We do know that. And we do think we do have some opportunities to make up for that in NPR, and we will be fully compliant when that goes into effect on January 1st, and we will not be increasing rates or prices in other areas to offset it. What we do have as an opportunity, one I mentioned earlier, I think we have increased opportunity in our inpatient daily census, both on the acute and swing side. And we also have identified some potential opportunity in our operating room to keep more Addison patients closer, Addison County patients closer to home in pediatric, dental, and ENT services. So we are confident we have an opportunity to make up for that NPR reduction. We just had run out of time to build it into the submission for the Green Mountain Care Board. And the other thing I'll call out as just a risk, because I don't think it's thought of a risk much when people think about critical access hospitals, and that is your Medicare reimbursement rate. As we learned with this most recent rate reduction, is that it's more than just your level of costs going up. If only it were that easy. But it's also related to, Medicare as a percentage of your overall business and the allowability of the cost that you're incurring, because all costs that an organization incurs are not subject to reimbursement from Medicare. So there's a lot that goes into it. We think we've got it figured out and directionally appropriate, but I would just call that rate increase out as a potential risk. Next slide. Okay. I think in closing, we just want to reiterate again, like the other partner hospitals, our budget was submitted in compliance with the Green Mountain Care Board guidance. But what I hope that Bob and I were able to show is that we've taken a step further than that and really taking on the mandates that we heard last year about looking for efficiencies and the cost reductions that come with being part of a network. And I'm proud to say that we've been able to demonstrate that in the budget we put in front of you. So with
Thank
that,
you. I'll turn to Member Merman for any questions you may have.
Yeah, great. Thank you. I first wanted to start with a comment on a component of your submission and your presentation that I think is really interesting, and is that you mentioned how you have improvement in workforce retention or reinforcement of workforce retention through the formation of the staff and technical professionals bargaining unit. And I think it's really interesting. It's great to hear the strong relationship between the hospital and the union with the intent of improving sustainability at the hospital, sustainable staffing, and workforce retention. So I think that's great. On page 7 of your submission, you say that contract labor / traveler FTEs are expected to exceed budget for 25, leading to 2.2 million in additional salary expenses related to travelers. I don't remember hearing that in the presentation. Is that accurate, that in 25 your contract labor is exceeding budget by $2.2 million? Your travelers?
That is true.
Okay.
And we do have milestones identified to turn traveler number over and convert to full-time staff, and that will be part of the information that we share subsequent, in line with what Member Holmes was asking about.
Okay, but so from 25 budget to 25 actual, you're up 2.2 million, but from 25 budget to 26 budget, you're trying to go down 2.9 million. So you've got a big drop from 5.1 million in traveler expense to go from where you are now to where you want to be by through the FY26 budget, right?
Correct.
Yeah, Member Merman, I can just add on that the reduction that I mentioned to Helen Porter has already occurred in their travelers already. So those have already dropped. And the inpatient traveler reduction, actually that process has started in July. And between July and October 1st, at the start of our budget year, we should be down to our projected traveler decrease, as I mentioned, through all the different hires. So contracts have been canceled. They all have to run themselves out. So there is a runway for this, and we feel very confident we're going to hit those.
Okay, so by October 1st, you're expecting to be at this 26 budget level?
We expect to be where we have budgeted, yes.
At the 19, what are it, 19, or I can't, I lost my page on the travelers, but okay. So the reduction is occurring, even though you're 2.2 million over in 25,
yes, we feel confident we will be at our staffing levels. Yes. Yep.
Okay. That will be impressive, and we will be interested to know what happens. All right. Just to clarify though, you mentioned Helen Porter. Is that 5.1 million swing inclusive of Helen Porter travelers as well as Porter Hospital travelers?
The number in the slide that we presented was only the hospital piece of that. There was a conversion with graduations of recent classes to get rid of travelers, and it's impacting both the hospital and Helen Porter.
Okay, but that 5.1 million swing, that's just within Porter Hospital, not within Helen Porter.
Correct.
Okay. All right. And then trying to understand the relationship between Helen Porter and Porter Hospital is a little tricky, because I think, we think of Porter Medical Center, but the way we regulate is different than the last hospital, which I recused from, I believe, is combined. So do you oversee both though, as Porter Medical Center CEO and CFO?
Yes.
Okay. Is there any allocation of your compensation to each of the organizations, or is it all paid out of one or the other?
There is an allocation. Yeah, there is allocation of both Bob and my time to Helen Porter.
Okay. And does Helen Porter pay for any expenses at Porter Hospital?
No.
And does Porter Hospital pay for any expenses at Helen Porter?
Other than subsidizing the bottom line, that's our contribution to their
through the margin. Okay. So I was looking at our staff did a really nice job and took the audited financials to look a little bit at Helen Porter, and it looks like you've been struggling with these losses at Helen Porter for a long period of time, but really pronounced starting in FY22. Prior to that, maybe averaging $2 million a year, and since then closer to $5 million a year. Would you just briefly describe the drivers of those losses?
Okay, I'll take a shot. It really started during COVID, and the impact that had on their ability to take on patients, not only take patients on, but staff up to take patients. And really, it's been recovery mode since then. I came to the organization in 2023, so I was came into the middle of this. But I know since that time, we've had senior leadership turnover, and we've kind of reorganized the way that we are looking at long-term care across the network in response to this turn of events. So it was, I can't put my finger on a particular thing, Member Merman. Honestly, it just has been a conflation of a decrease in census, and the rate that they were paying for staff and travelers really took its toll for a 2 to 3 year run rate.
Okay. And it looks like in 24, Helen Porter had a loss of about 5.2 million. And what I think I saw this year, you're projecting a loss of 4.6 million. Is that correct?
Yeah.
Okay. And in 24, I think I see that Porter Hospital had a 5% operating margin. And this year you're you're hoping to get a 6.9% operating margin.
In FY26, yes.
Yeah, 26. Thank you. Okay. One other thing in the narrative that's kind of tricky for me is this admin to clinical ratio section. When you didn't calculate the ratio, so when I calculate it though, it's pretty high. One of the highest I've seen. Can you discuss why you think that's the case?
I don't have that chart in front of me. Remember, do you happen to have it to pull it up?
I have it in paper. It's page 16.
Of the narrative.
How about I send you that in follow-up, and then we can talk about that and keep moving here.
Right.
When you talk about 323 patients added to primary care, is that a net increase to the primary care panel at Porter?
That's my understanding, yes.
Okay. Are there any new primary care providers that joined in 25? Well,
This current, yes, there are new primary care physicians. Yes, there are.
okay. It's a pretty modest increase for if you've hired anybody. I mean, a typical primary care panel. I don't know. Do you know what your panel size is at Porter typically?
I can defer to Brad on that one.
The average across the network is about 1150 for physicians.
Okay. So I think I would look forward to higher access, but I think that makes sense because it looks like you're predicting to increase your work RVUs for physicians and primary care providers in the outpatient setting. So that's optimistic. Response to board question number 4. This is discussion about this pediatric density